Okay. Good morning, everybody. I am Dr. Sudeep. I welcome you all to the ACVS from the Department of Pediatric Cardiology. Yesterday, we did perform one coarctation stenting with Dr. Saibal Kar. I am presenting the same coarctation stenting patient. So, this is around 11-year-old girl with having a history of hemiplegia 8 months back with partially recovered with high BP noted at that time at present on antihypertensive and BP is controlled. Neuroimaging revealed small infarct. Suspect to have CHD initially in view of the hypertension, and because of the clinical examination they found radiofemoral delay. Underwent cath 6 months back and we decided to go for the coarctation stenting. On examination we found its radiofemoral delay present, systolic murmur in the back at the interscapular region as well as the lower thoracic region with BP at present of 160 with controlled on medications. So this is the lateral angiogram what we performed with the marker pictate. You can see there is a discrete coarctation at the post-subclavian level that measures around 7 mm, and you see the PDA ampulla with the aneurysmal segment that is having calcified. There is no PDA present, and there is an irregularity of the descending thoracic aorta. So with that in the view, we thought it's definitely Takayasu arthritis with multiple level obstruction, although the obstruction maximum at the coarctation level in the post-subclavian region. So we thought we'll go with the coarctation stenting. This is the AP view that shows the same. There is no presence of collaterals and there is the irregularity of the descending thoracic aorta. So the dimensions what we measured are the coarctation segment is around 7.5 with pre-segmented 9 mm, descending aorta of around 14 mm with the subclavian artery well away from the coarct segment. So with that in the thought, we thought we should give some renal angio also to look for the descending abdominal aorta as well as the renal angio. In that view, we did this angio. We found out to be there is a obstruction at the renal level abdominal aorta also with the stenosis of the right renal artery. So the issues after this, we initially thought to go straight forward with the coarctation, but after doing this angio, we thought there are a number of issues to be taken out, whether anything to be done at present or not. Second, what will be our approach in this, because there is a constriction at the multiple level. What if stent to be used, what stent to be used, or is the balloon suffice for the coarctation stent? So after discussing with the Dr. Saibal Kar and all, we thought there is the maximum obstruction at the upper level. So if we relieve that, there will be the relief in the symptoms and there will be the relief. And second, lower down it's very difficult to approach at this moment because there is this involvement of the right renal vein also, right renal artery also. So we thought we'll go ahead with the balloon dilatation, we'll see the results, and if required after that, if the results are good and it's satisfying, we can go ahead with the stent. So with the same view, we decided to go with the 12 mm balloon because the diameter of the coarctation segment is 7.5. So we can go about 1.5 to 2 mm, 2 times more than that. So we decided to go with the 2 times of that is 1.5 to 2 times. So we decided to go with the 12 to 14 balloon. So in the shelf, we have 12 Fox plus balloon. So this is the image that shows which the balloon we crossed across the coarctation segment, and you can see easily the indentation of the balloon. This is the place where the coarctation segment is there, and this is the place where the calcium is there. So you can see the indentation. So after the full balloon dilatation with the 8 atmospheric pressure, we see these results. After that, the pulses marginally improved, the graph of the femoral pulses improved. So we thought we will go with that because the pressure, there is no as such gradient is coming in between the descending aorta. So probably it may be because of the capitation at the upper coarctation level that is causing no gradient at the lower coarctation level. So we thought we'll reduce at least one, and in the graded way, later we can tackle the renal artery and we can tackle the descending thoracic aorta as well as the abdominal aorta. So with the same view, we thought we'll go with the covered stent. As you know, this is the tortuosity is there. There is more risk of dissection, and the PDA ampulla is there with the calcification. We thought it's better to go with the covered stent. So we deployed 12 into 30 Atrium Adventa covered stent. So you can see this is the image that shows the nice opening of the covered stent across the coarct segment. This is the full inflation and full deployment of the stent. So we thought our job is finished at this point because the pulses appear, the BP improved in the lower limb. But if you see here, there is flaring of the, there is still the very good waist is there. So we thought we can go ahead with the more than that with the 14 balloon also. And there the flaring is not very good. If you see in the upper and lower end, the flaring of the stent at the proximal distance is not very good. So we thought we'll go with the 14 balloon again with across this stent, and we can dilate that. So with that in the mind, to stabilize the stent, to approximate that stent to the wall of the coarctation so that the stability will be more, so we decided to go with the 14 balloon dilatation again after that. So this is the Atlas balloon 14 into 20 with the big shoulders. You see there is the after dilatation of the balloon, there is the disappearance, and this is after the final angiogram after the balloon dilatation. That revealed a very good flow across the stent, and after that we checked the gradient across the ascending aorta and descending aorta. There is only 5 gradient across that, but when we measured after from the descending thoracic aorta to the abdominal to the femoral artery, we got the gradient of 30. So that suggests that abdominal segment, what is across perirenal artery, that is also significantly stenosed. So we thought what we'll do, we can do after some time with the graded approach. So this is the final angiogram, and this is the final stent position that gives very good result over here. And this is the data, hemodynamic data, what we measured during the procedure. You can see there is a gradient of around 30-34 across the abdominal aorta at the renal artery level after the stenting. So the issues after the procedure, BP is stabilized, no, the pulse is improved. It's not very significantly improved, but marginally it improved, and the pressure is very well. So the issues what we thought after that, it's a renal artery, we can do in a graded approach. Over the later time we can put either the open cell self-expanding stent, so that because the renal artery origin is also involved in that. So this time we did only the coarctation upper segment, and that gives a good result. So we thought in the graded approach later we can tackle the renal artery and as well as the abdominal aorta also. So
I think thank you Sudeep for excellent demonstration of coarctation of aorta stent.